So we now proceed to our next session, that is caring critically ill oncological patients. How are they different from other sick patients in ICU? So to chair the session, I would request Dr. Vishal Bhatnagar, who is a consultant and head of surgical oncology, ICU, Rajiv Gandhi Cancer Institute. Dr. Vishal. And Dr. Brigadier Arvind Kumar Tyagi, who is the Director of Surgical Medical Oncology at Yashoda Cancer Center.
A very good evening to the illustrious gathering here. I am a newcomer here into the city, first from the army into the civil and then from civil out of Delhi into Ghaziabad. So it's my honor to introduce Dr. Prakash Shastri, who is the Vice Chairman of Critical Care at Sir Gangaram Hospital. And as an oncosurgeon, I really value the onco-critical care team, and I wasn't aware that there's a society which has just come up, and I think it's for the right reason that this society has come up now. Please come to the dais to deliver your lecture.
Thank you very much to this entire team for having invited me here, and it's indeed a great pleasure to be coming to Rajiv Gandhi Hospital. At the outset, there are a few disclaimers that I want to make. I am from Gangaram Hospital, which by any stretch of imagination cannot be called as cancer hospital. So your whatever you said was probably superfluous. But all the same, we have had enough exposure to oncological patients for several reasons, because it's such a big hospital, one of the oldest hospital, and quite a favorite of people staying in this part of Delhi. I would like to pay my tribute to, take this occasion and pay my tribute to Dr. Dinesh Bhurani, who actually invited me over several times here to see his cases and especially give him inputs on probably fungal infections in oncological patients. And this was a sort of a joint effort, and we also entered into a study in which we basically we decided to see what are the outcomes of patients who are infected by filamentous fungi in hemato-oncological patients. And I must admit, this was a huge learning experience, and that is why I owe this knowledge and whatever I know about medical oncology to Rajiv Gandhi Cancer Hospital. So, as has been alluded to by various speakers before me, the majority of times the patient comes to the intensive care unit for basically reasons related to the lungs. And that is perhaps what I would really deal with. Other things are there. There are several reasons for which the oncological patients come to the ICU, but majority of time it is always to do with shortness of breath, saturation going down, blood pressure going down. Those are the conditions where the patient is shifted to the ICU. But this is the time where the onus of responsibility falls upon the treating physician. He has to make a judgment, and this is a clinical judgment. He has to decide whether I should send my patient to the ICU or can I manage this patient here. Now again, a disclaimer, I must tell you that I started training in critical care when oncological patients, cancer patients were, especially hematological cancer patients, were not candidates for ICU admission, because I worked in a setup where it was free of cost, so it was waste of resources, as they put it. And that is from in the last 1 decade, there has been such a huge improvement in the management, huge improvement in the amount of drugs and other facilities which are available to cancer patients, that the outcome of these cancer patients have improved tremendously. And obviously, in the last 10 decades, 2011 was the time when Supreme Court declared critical care medicine as a specialty. So maybe both of us join hands and both of us move forward, and that is why today I can say, having had training in that era in which hematological oncology patients were not candidates for critical care, nowadays I can say that I give full Monty. I do everything for an oncological patient who comes to my ICU. Now, the duration for which I do it, that is debatable. So most of the time, patients coming to me from the ward, relatively stable patients, otherwise they wouldn't have come to ICU, I would probably treat them full Monty for 7 days. At the end of 7 days, I need to go back to my drawing board and see what am I doing, what am I getting something. ICU is an exceptionally expensive proposition. And cancer patients are just not cancer patients for 1 day or 2 days, they are cancer patients for 1.5 years perhaps. And they have already undergone a big burden of economic hardships to come up to this level. So that is something. But in a small subset of patients who almost came moribund to the hospital, they came late to the hospital, they were referred to us late. They thought that coming to my hospital would make, I'll move around a magic wand and make things better. There, I take a call at 72 hours. And this is where there is a huge amount of difference between me and oncology colleagues of mine. Because at the end of the day, if I have to take a call as to whether I should continue my treatment or whether I should call it a day, I am really not the right person to talk these things with the patient's relations. Because the medical oncologist is the person who has been managing the patients for 1.5 years. And suddenly a new person comes in and he starts dictating terms saying that I am managing your patients. So their medical oncologist or their hemato-oncologist is God to them. They don't accept it. And that is why we brought up this concept of teamwork. So whenever we are discussing the prognosis of the patient, it is a good idea that the two persons are actually together, and actually that person should introduce me to the family, saying that the intensive care part is his domain and he would be telling you about that. In general, I'll be coming every day, I'll be talking to you, but what I would probably tell is he's getting better or he's getting worse. But the intricacies of critical care is going to be described by this gentleman. And from there on, then they develop the confidence in me. They understand that it's just an extension of responsibility which has been handed over by his God to me, and then we take it forward. So that is one area that I would really like you people to go about and think a little bit on communications to the patient's relations, because that is one area which is not taught to us in our medical curriculum, and that we have to develop as we go along. So there are various criteria for ICU admissions. I would not go too much into them. But, and again, no rocket science to tell me that I need to cohort my patient, I need to segregate my patient in isolated cubicles so that they don't get infected by others. There should not be any plotted fire plans, and we should not be eating and drinking inside the ICU, those kind of things I don't need to tell. But more importantly, we have got what? 3 plus 3, 6 and 2, 8 and 2, 10. 10 isolation rooms in my ICU. And if you talk about positive airway pressure rooms, we have got just one. So we have got such a dearth of this kind of isolated rooms, and that is why if you are looking at a cancer hospital and you are looking at critical care, you need to make sure that these things are in place. I know that these things are mandatory for bone marrow transplants. Bone marrow transplant is a different world altogether, and probably I don't even get to enter into it. But for the rest, it is not so easy. And that is why, again, just remember, in the 90s when I started my critical care, hematological oncology patients were not a candidate for critical care because the mortality was almost 100%. So, one more thing. India is a country in the making. There is construction activity all the time. And Mrs. Yadav is there in front of me, and she would say that, yes, there is something happening all the time in the hospital. And the worst thing is that it happens all right. But it is the least that they should do. If it is in the vicinity of my ICU, it is in the vicinity of pediatric ICU, high dependency units, at least inform us beforehand. No, one fine morning you just come in and you are wading through the dust into your ICU, and then you're making probable diagnosis of aspergillus in all your patients. So construction activity is something which, if it is done, it needs to be done with adequate precautions, and I'm sure your medical administrators know it pretty well as to what to do. So there are risk of infections in the critically ill patients who have a background of malignancy. And not surprisingly, they come to the intensive care unit for organ dysfunction. And as I said you just now, that we are exposing them to an environment which has got potential pathogens, which are opportunistic pathogens. You and me are probably not affected by it, but these are immunocompromised patients. For them, these innocuous organisms like aspergillus, for example, and I'm sure quite a few of you have gone for holiday, they have left a piece of bread on their dining table, they have come back to see that bread becoming green. But that doesn't mean that you get aspergillosis. But my patients would, my ICU patients would. And then there are several other things that also confound the picture. And one thing that really interests me is the presence or reactivation of CMV virus. I would definitely say that your success on treating this patient depends upon the net state of immunosuppression, which is an estimate, which people like him know very well. You have to make an estimate what is the net state of immunosuppression. Now let us say that if the net state of immunosuppression is 100, just an arbitrary figure, and this patient gets CMV positive, his net state of immunosuppression would become 150. So that much more difficult for me to handle this patient. So these are several reasons why these patients are very, very prone to infections, and algorithms of this kind of timelines of infection, and this is stem cell transplant, but it almost should be applicable to quite a lot of other things. Even in a solid organ transplant, there are timelines, and in the last conference I had spoken about solid organ transplants and timelines of infection. But the important thing is for you to know is that in the initial period of on bone marrow transplant, we have the usual flora and fauna of your ICU, which is gram-negative bacteria, gram-positive bacteria, or the skin contaminants, which tend to infect the patients. It is only later on that you get pneumococcus and other things. Similarly, among the viruses, herpes simplex is reactivation of herpes simplex, which was probably there in the body beforehand. And there are other viruses, HIV, for example. But then, if you look at fungal infections, Candida probably becomes a bit more predominant in the early part of the transplant, but later on in the transplant, much later, we come across PCP pneumonia. Very, very hard to treat and very difficult, very painful, because they tend not to make it. But if you look at aspergillus, and I spoke about aspergillus just now, ubiquitous. It's a ubiquitous organism. It is there all over. It is there in this room, perhaps. So probability of aspergillus is there right from the beginning to the very end. So that is something that has to be there in your mind whenever you talk about infections. So what about the fungal infections? So you can see the blue is the aspergillus. Majority of time the infection is, and among the fungal infection, is due to aspergillus. Candida, mucor, much less, 75 to 25 ratio. So that is the thing. Mucor, the least, mucor is very less, and the next is Candida, of course. So hopefully I'll walk you through a few cases where we can tell you that early recognition, early management, early referral to the ICU probably made a difference. And let me tell you, I'm not going to tell all your success stories to you. Behind every success story that possibly I might tell, there are 5 cases where I failed. So that is the kind of environment that we work in when we are dealing with cancer patients. Myelodysplastic syndrome, refractory anemia, post-match unrelated donor, transplanted, bone marrow transplant drain, gets into a relapse, receives intensive chemotherapy, goes into prolonged neutropenia and fever, and develops a skin lesion. Very innocuous looking. I'll show you the picture. But something struck the medical oncologist, probably because the way he talked to him, he thought that he was going into encephalopathy. He transferred the patient to the intensive care unit, and this is what we got. Neutropenic patient, ANC 0, renal functions all right, LFT deranged, slight hyperbilirubinemia. If you look, the last one is serum alkaline phosphatase. Alkaline phosphatase is raised. Now we can talk about that later. Galactomannan. Now this is the protocol. All immunocompromised patients tend to get serum galactomannan. Immunocompetent patients, the normal standard ICU patients, even if I do a serum galactomannan, it will come as negative, because you have active neutrophils, and active neutrophils will devour all the galactomannan that is coming from the patient's fungus, and that is why routinely you don't get serum positive. We'll talk about BAL galactomannan later. So BAL blood culture was negative. This is the kind of skin lesion. I hoped, I tried, the picture would become much better. It's just like a blister on the knee. X-ray. A bit of shadow here and there, and as you can see, if I can see, a bit of ground glassing on this side, a bit of ground glassing that side, and definitely some kind of an infective pathology, I'm sure. But that is not very innocuous. What about the results? Skin biopsy with it. So we, again, cancer patients, thrombocytopenia, bleeding disorders, very invasive procedures, unlikely. But this was a surface lesion. We went in for biopsy and we got fusarium, a fungus, and we got septate hyphae. Now let me tell you, ladies and gentlemen, majority of time, maybe 90% of the time, that if you're seeing a septate hyphae, it is aspergillus. So what we did a bronchoscopy. And this is a plaque. This is a white plaque. And if you see a plaque, you're almost certain that you're dealing with aspergillus. It could be flavus, it could be fumigatus, but it is aspergillus. But having said that, you are taking out aspergillus from a bowel, from lung secretions. Now, lung is not a sterile site, and that is why even if you grow it, if you culture it and you get the species, you can only make a probable diagnosis of aspergillus in this patient. I hope I've made myself very clear. Second case, all that mumbo jumbo. Only thing that I can tell you is that is B cell lymphoma, BALL, and in addition to that was Hep B positive. CNS prophylaxis given, and you heard about complications of drug therapy. This gentleman had everything. He had neuropathy, he had AKI, which needed dialysis, but despite all that, and he had recurrent ear infections, and then he had COVID infections also. All these things happened, but he was kept on chemotherapy, and ultimately he was now down to maintenance chemotherapy. On day 11 of maintenance chemotherapy comes to our casualty, typical sepsis, facial swelling, ear discharge, inability to swallow fluids and liquids, treated with antibiotics, ENT consulted, they just applied the antibiotic. This patient had hypokalemia, shortness of breath, desaturation, and that's why it comes to the ICU. Innocuous looking patients to begin with, no focal neurological deficit, answering his questions. But left-sided facial swelling was quite prominent. In the COVID days, we would have made a diagnosis of mucormycosis, but in this case, we were not, because the proptosis was not there. But what he had was a red, inflamed ear, probably an otitis externa. You can see that he was in florid sepsis. Okay, we're just compensating, but definitely he was in sepsis. TLC 180, ANC 70, platelets 21, creatinine is 3.49, bilirubin 1.97. So obviously he is in serious soup. He is going into multiple organ failure. Started on non-invasive ventilation, antibiotics escalated, fever persisted. So antifungals were added empirically, became worse, got intubated. The culture from both the ear as well as the blood showed drug-resistant Klebsiella pneumoniae, which was only moderately sensitive to colistin and minocycline. And this was the point of time that I had talked to the family. Family almost begged me that relieve him of his misery. Please do something so that he dies in peace. And I tried to call the treating physician. I could not get a response. I had to deal everything myself, and we pulled out in this patient, and he had a peaceful death. That is what we ensured. Another case, 2018, a picture of almost meningitis that you can say. He was an AML patient. I didn't mention it here, sorry. AML patient. So since he was the pictures of meningitis, we did an MRI, and what you see over there, you can see the cerebellum, I'm sure. And this cerebellum is lighting up, and the reported was multiple abscesses in right occipital lobe with moderate to significant perilesional edema. Took him for operation, craniotomy done, abscess drained. The pus was reported as nocardia farcinica. It was sensitive to antibiotics. The patient is still there with us. We have tracheostomized him. We have sent him to the high dependency unit. Only yesterday I talked to them regarding the possibility of home care, because I'm not going to remove the tracheostomy. He is otherwise quite stable. He has completed 3 weeks of linezolid therapy. Unfortunately, we had to stop it because he developed thrombocytopenia and we had to give him platelet transfusion. So you can see that as the time passes, as the degree of immunocompromise goes up, we have normal infections like influenza, and HIV, chronic leukemia. But when the immunosuppression, degree of immunocompromise goes high, we have what we see in solid organ transplants or patients who have had CMV virus, leukemia, profound neutropenia, the degree of immunocompromise is going up, and finally we have the bone marrow transplants where it is the maximum. And this is the patients who, when they come to the intensive care unit, we are fighting with the infection with our backs hand tied to the back, because the patient is not going to mount a response. When my patient actually has fever, he has got tachycardia, I am happy that he is mounting a response. Because if it doesn't, and more often than not, these immunocompromised patients do not mount a response, so you are not even suspecting sepsis in this patient. Like I told you about in my case, he came and looked innocuous, was conscious, talking, but he was in organ failure. So I understand my hematology or oncology colleagues, medical oncology colleagues are always doing tightrope walking. They want their patients to get better, and they know these are the drugs that will make them better. But they also understand that these are the very drugs which in India, for some reason or other, the infection rates are so high, we tend to get them. I can give you an example, peritoneal dialysis, something which has been started on a community basis from Gangaram Hospital. If the husband is looking after the wife, the patient comes with COPD peritonitis in 3 months. If the wife is looking after the husband, COPD peritonitis 3 years. But at the end of the day, it happens. So these infections are very, very common, and you can see that if there is an add-on infection to a cancer, the mortality goes up by 1.5 times. So there are current challenges, delayed diagnosis, underdiagnosis, because as I told you, the inflammatory response is not there, symptoms are non-specific. Standard histopathological diagnostic techniques like biopsy are precluded because of thrombocytopenia, bleeding disorder, or the lesion being too deep for us to go, and culture-based techniques are too insensitive. More often than not, I always get negative cultures, and even if I do get some positive cultures, they come to me after 7 days, especially in case of fungal infection. So they are not too much of help to me. So what do we do to meet the challenge? We make sure that we have a high degree of clinical suspicion. We try to make an early diagnosis with whatever means that are available to us. Maybe the new biomarkers are coming up nowadays, and we talked about BAL, galactomannan, we have beta-D-glucan and this kind of things which have come up now. And early initiation of appropriate therapy. The appropriate therapy for the medical oncologist means everything: gram-negative, gram-positive, antifungal, atypical, you name it. So you throw everything at the patient and then maybe narrow down later on. Thank you very much for your patient listening.
Thank you very much, sir, for a very nice presentation. In a very short of time, you try to explain everything. Any questions?
The audience doesn't have a question. I have a question for you, sir.
Sure.
What about this biofire that we are? Lab has recently started doing something called biofire, where they give you a culture or antibiotic or the bacterial.
Good question.
Within few hours.
Good question. I'm a bit biased. So the biofires are PCR-based techniques. The PCR-based techniques are basically based upon algorithms which have been put into the machine, and on the basis of matching of the algorithm, you make a diagnosis. So PCR techniques, in general, I'm a bit skeptical. Having said that, CSF being a sterile fluid, the meningitis or encephalitis panel of PCR has given us fairly good results. I will not depend upon PCR of the respiratory secretions. Whenever, even now, I'm sure quite a lot of people would say that I do an RT-PCR first rather than do a respiratory biofire. In dengue patients, in COVID patients, and other patients, we do an RT-PCR rather than a film array kind of a technique. So I'm a bit skeptical. I think the technique has not been standardized. Maybe there are a lot of pitfalls in where false negatives are there, and sometimes you tend to get innocuous pathogens which you unnecessarily treat. And that is why false positives are very common. I take it with a pinch of salt. Yes, to begin with, I am making a clinical diagnosis of viral pneumonia and I get an adenovirus in the respiratory biofire, I would know that I am on the right track. So to that extent, I manage it.
Thank you so much, Dr. Shastri. I would now request our chairpersons to kindly felicitate Dr. Prakash Shastri. Thank you, sir. May I now request Director Anesthesia, Dr. Rajiv Chawla, to felicitate Dr. A.K. Tyagi.